A very big hello to all my dear students. How are you all? Welcome to the T2O series on your favorite channel, You and I with Dr. Ruth. So, Neetpg is around the corner. Are we ready? So, I've decided for the just before the Neetpg for few classes, a few sessions, we are going to discuss some important topics that has been asked in your exam. It will be an image-based discussion, but yes, it will all be based on whatever has been previously asked from. Okay, so let's start. So first look at this. What are you looking at? So these are your radial spokes, right? So radial spokes, what are we talking about? About cortical cataract. What is the other name of this cortical cataract? We can also call it cuneiform cataract, right? The question recently asked in NEET PG was about the management. So we have to revise the different surgeries here. What is the best option and managing? Of course, we know it's all surgical for cataract. And in surgery, what can be the options? Either it is ECC with PCIOL, number one, right? So when you say ECC with PCIOL, very, very quickly, we all know ECC means that we are removing the central capsule, right? Cutting from the anterior capsule from the center. Once you cut the anterior capsule from the center, remove the cataractous lens, and put an artificial lens. The basic, this is what is extra capsular cataract extraction, leaving behind the capsule with posterior chamber intraocular lens, right? So this IOL is made up of, this is another exam question. We all know it is polymethyl methacrylate. What are the other surgeries? I don't think this was actually in the option ECC with PCIOL, and you had to mark it among the. This was one of the best options among the four. But yes, of course, if you ask me nowadays, what I will do, I will either opt for phacoemulsification or or I can go for your femtolaser cataract surgery. Isn't it? So very quick phacoemulsification. What are the questions asked? If you remember your phacoemulsification, we make a very small incision length is asked first. So if this is your, so if this is your dilated pupil, right? We give a clear corneal incision. First question is what is the size of the incision? There's 0.3 to sawa 3, that is 2.75 mm to 3.2 mm. This is your first question. Second question, what you have to understand is once you all remember your phacoemulsification, what do? We do a CCC, that is capsular axis, which is continuous curvilinear capsular axis. A quick revision here. So once there is of course a side port to manage the whole process. Once you have made it and you have made the CCC or capsulotomy, right? Uske baad, what next? Of course, you do hydrodissection, separate the capsule from the lens, rotate the nucleus that the hydrodissection is complete. Then we do not take out the nucleus, but instead we take the phaco probe inside the capsular bag, and with this we phacoemulsify, eat up the whole nuclear part and aspirate. And later we are going to aspirate the cortical matter by irrigation as cannula, and we will put foldable IU. So the next question that they ask you here is what is the frequency of the phaco probe? You are going to answer frequency of the phaco probe is your 40 kilohertz. It's the best answer that you should give. Of course, foldable IOs, they are mainly made up of acrylic and silicone. They're made up of acrylic and silicone. That you have to learn. Most commonly used is acrylic. Right? Okay. And what is the next surgery? Of course, is femtolaser cataract extraction. Again, we have learned about femtolaser cataract surgery, femtolaser assisted cataract surgery, isn't it? So, what does a femtolaser do? It can, that is making of the incision or breaking the lens fragmentation. Learned all, right? So, we will remember this. The question asked is what is the pulse duration of the femtolaser? It is 10 to the minus 15 seconds. The pulse duration is 10 to the minus, right? Okay. So that is about femtolaser assisted cataract surgery that you should know. And what is the third step? What you can do is, of course, capsulotomy. These are the three steps we do through laser. Those capsulotomy. Okay, right. So here, this was your first slide. This was given exam. So I hope you are now clear. Then we come to next question was on limbal dermoid. This was a picture given. The hair is coming out. This is, you all know what is a dermoid. It is a choristoma. This is limbal dermoid. There's confusion between this limbal dermoid and what is the second one? That is lipodermoids. Not only dermoids, it is lipodermoid. So this is a lipodermoid, right? So when you say lipodermoid, it is generally it is continuous with the orbital fat. You have to keep it, okay? And it is generally seen continuous. So the adipose tissue, mainly adipose tissue and connective tissue, and it is continuous with the orbital fat and more common. So whatever it is, we have to keep in mind that generally both dermoids as well as lipodermoids can be associated with golden heart syndrome. Okay. And then what is this? This is your dermoid, orbital dermoid system, which you can consider as, we used to learn as most common non-ocular, most common, so sorry, yes, most common intraorbital but non-malignant. That means benign tumor in the children, most common benign tumor intraorbital in children, dermoid cyst, but now we will learn it as capillary hemangioma. Okay, so this can be considered as the second most common. I say this is the benign, when I talk about the benign tumor, which is intraorbital. This is said. Okay, then we come to the next question. The next is this, of course, again repeated question in all exams. I hope you are very, very clear. We are looking at what? What is this? I can see the edematous area here and a red spot. Yes, we are talking about cherry red spot. Right? So cherry red spot, what are the points they have asked you is about the causes. And we all know if it causes, I have taught you, you can learn in three broad headings. One is your, of course, Berlin's edema, right? That is commotio retini. Second can be central retinal artery occlusion. And third can be your, the heading just gangliosidosis and sphingolipidosis, that is, call it as deposition. We'll keep this in mind that of Tay-Sachs, I'm just talking verbally here, Tay-Sachs disease, Niemann-Pick, Gaucher's, type 2, yes, we do get. Okay, so there's a debate here, but yes, we get cherry red spot in Gaucher's, Krabbe's, Sandoff, Cialosis, GM1 gangliosidosis type 2. All these are causes of cherry. Right? Second question is that if your patient is not blind even after CRO, then definitely there's a dual blood supply. What artery is this? This is what is your cilioretinal artery. You say cilioretinal artery. This is a branch of short posterior ciliary artery. The branch of short posterior ciliary. Okay. We come to next slide now. Is there any other question they can ask you? Yes. One question here is, what is the time limit? Within how many hours or seconds? What is the time limit? Within how much time I can treat it so that I can save the retina, otherwise there is irreversible damage. So you're going to answer 90 minutes. Okay, that is 90 minutes. Is the critical. Within 90 minutes of CRAO, if we can treat, then otherwise there is irreversible damage to the. So these are few important questions around you should know. Okay, next we talk about is another slide. This is also exam question. As you can see, there's a deposition of this elastotic fibrillar material that is seen on the anterior capsule and on the sensory ligaments, pupillary border. Yes, you are guessing right. We are talking about pseudo exfoliation syndrome, right? So when you say pseudo exfoliation syndrome, in pseudo exfoliation syndrome, what are the things that you have to remember here? This is one of the most common secondary glaucoma. The same material is going to block the trabecular network and close the angle. So it leads to secondary open angle glaucoma because there is a blockage in the trabecular, right? And what is the sign known as? What you're looking at is called either hoarfrost sign or target sign. Why is there no deposition in the middle? Because this is due to rubbing of the by the iris. Okay. So what happens? This material is all washed away due to rubbing of the iris out here. There is the material is not seen. That is why you get this clear area. So this was about your pseudo exfoliation room that you will correct. Okay. They don't ask you about the genes and all, so I'm not going into all that detail. Only the things that are asked in the. Okay, we come to the next thing that I have asked you here is your about what are you looking at? What are these nodules here? These are Dalen Fuchs nodules, right? So we are looking at Dalen Fuchs nodules. If you just understand in my way, simple way, where are these nodules present? You can make a diagram here that if suppose this is the outermost layer of the retina and this is the retinal pigment epithelium. And what do you see here? This is your choroid. So there is a membrane that is, what is that called between the two, which is the inner layer of choroid. This is what is your Brooks membrane, right? This is your Brooks membrane. So what do we see? That nodules are present between the Brooks membrane and the retinal pigment. So between Brooks membrane and retinal pigment. This is what you have to know. These are called Dalen Fuchs, right? So this is, what are we talking about anyway? Sympathetic ophthalmitis. And what are the other points we have to remember in sympathetic ophthalmitis? Suppose it is perforating injury in one eye causing uveitis in the other eye. What is that type of uveitis? Granulomatous pan uveitis. Because it is happening in the other eye also, that is a sympathizing eye. Remember, it's always perforating injury. Another important point here, it will only occur due to immunity against the uveal antigen. So this will take at least 2 weeks. So it will never happen before 2 weeks. Never before 2 weeks. This is another important question. Remember, never before 2 weeks. What else? Another important thing that we should also remember is what is the sign. So the first sign is always you start getting inflammatory cells behind the lens, which is what? Retrolental flare, right? First sign we will answer here is retrolental flare. Retrolental flare. Correct? And what is the first symptom? Because it is the first sign is here. So what is the role of the ciliary muscles? Accommodation. Therefore, the first symptom you should always answer as difficulty in near vision. First symptom is difficulty in near vision. Okay, or difficulty in accommodation, near vision. And second choice you write as foot. Second choice would be. Okay. So and what are you looking in this slide is nothing but these are your mutton fat KP. These are the mutton fat KPs. Fat. Okay. Anything else we can remember regarding KPs? That they are maximum at the lower cornea, right? If I make a diagram here, the KPs are maximum at the lower cornea, and this imaginary triangular area where you get the maximum KPs, this is what is called arched angle. What is arched? Okay? Okay. So that was a quick revision. What are the topics you have to? I'm also giving you an idea that if don't remember things in this topic, please revise the topic. There has been a question on sympathetic ophthalmitis, which will be absolutely clear to you. I've just discussed all the there. Then talking about pseudo exfoliation, which is nothing but secondary open angle glaucoma. right? We learn it along with pigmentary glaucoma, if you remember, where there is dispersion of pigments. Here it is the mainly the dandruff-like material, which is not a fibrillar material. Is also, yes, you can also see what are the findings is that on the pupillary border you will get the same fibrillary material, right? This is your pseudo exfoliation syndrome. And what's technically very difficult, you have to understand clinical significance here is very difficult when you're operating a cataract to save the capsule. It tends to come out during. So we have to know whether this patient has pseudo exfoliation so that we can be very, very careful and have over it, right? Then we talk about another. So the questions I have already mentioned, what were the questions asked? Okay. We come to next. Next, what you have to know, what did we discuss was cherry red spot. It has been discussed many times, but yes, very, very important, and you should remember all the questions. Correct? So if you have any confusion for the, because I have not listed the depositions, I'll do it again for you all. Depositions, of course, Tay-Sachs, Niemann, Pick. Right? What else? Third, I said is Gaucher's also. Then I told you GM1 gangliosidosis. This is type 1. Oh, sorry, type 2 has red spot, not type. Then also your Krabbe's. So the list goes on and on. We don't have to mug up the list. The main ones that is asked that you have to keep in mind. Right? Tay-Sachs, you should be very, very clear about even the seismic fact that there is no hepatomegaly. So just revise the seismic. Was also asked in it. Then what else? And okay. Now it's more complete, right? Then we talk about next is your, did we talk about lymph? And what is the most common malignant tumor in the orbit for the children and adults? Can we do that as well? Is it most common intraorbital malignancy? Then for children, we will learn what? Rhabdomyosarcoma. Remember this? And for the adults, what are you going to learn? Is your lymphoma. Which cell type? It is non-Hodgkin B cell. Non-Hodgkin B cell. This is your most common intraorbital malignancies that you. Intraocular क्या है? Children it is retinoblastoma and for adults it is corneal malignancy. Not given that and justice. Right? So that was about intraocular. Okay. That was a quick revision of few topics that they have asked in your Neetpg. Hope you enjoyed the session, and we'll be taking few more in the next Tuesday. Right? Thank you so much. Keep revising with me. Stay blessed and keep